Larry described most of you as the penultimates. I'm the ultimate, and I say that with no arrogance. I think I'm all that stands between you, Larry, and wine. So I'm going to try to be succinct. Here's what I'm going to do. I want to talk about a couple of things looking back. I want to talk about electronic medical records, patients helping decide about their treatment, and about evidence-based medicine. I was delighted by the discussion yesterday. It was one of the funniest and most delightful and engaging speeches that I disagreed with almost everything about. So that's what I'm going to do. I'm going to talk about that for a little bit. And then I want to talk about two things looking forward on which we will, on which much of what we talked about yesterday and today will be built. And that is care integration and the consumer health ecosystem, which Bill really has talked about. He used a much more refined and elegant way of describing what I have crudely called the consumer health ecosystem. So first, let me talk about the electronic medical record. Who's at fault here? Is it the tractor's fault or the person who's hanging off the end of it? Yesterday's slam at the electronic medical record, to me, missed a very important point, and that was blaming the wrong thing. Electronic medical records are absolutely essential to 21st century medicine and practice, and for anybody who doubts that, simply imagine how in the world you are going to carry around in your brain 4,000 nonsense gene mutations that cause 4,000 different clinical conditions, most of which are orphan diseases that occur irregularly. Impossible. The problem with electronic medical records was identified, and that is that they are often, the electronic medical record solutions have often been built without attending to the needs of the clinician, nor have they been implemented in such a way that the clinicians learn how to lead with their right foot after having learned to dance with their left foot through most of their careers. When we implemented the EMR at Kaiser Permanente, the key thing that we worked on was re-choreographing what happens in the doctor's office with the doctor, with the clinicians, so that exactly what was described yesterday does not happen. And that is that you become impassioned with the consumer and forget that you're taking care of a patient. That should never happen, and if it does, this is the reason. We've not attended to the human side of things. It is not the fault of the tractor. It's the fault of the people who are trying to hang on to the tractor. When I drove my tractor the first time I ever drove it through the side of my barn, I did think about getting rid of my tractor, and I kicked the crap out of it and broke my toe. It was the wrong diagnosis. Secondly, about patients making their own decisions, of course not. A straw man. However, let me tell you how critically important it is. Jonathan talked about this with regards to veterans. The same issue is true with virtually any chronic illness. The whole principle behind the social networks that Bill talked about is that individuals and groups bring biases, bring values, bring desires, bring life circumstances, bring their stochastic events to bear on a problem and have to be partners in the process of deciding what needs to be done. The problem has occurred when physicians assume that they're the ones who should be making those decisions for the patient. Let me give you an example. My 91-year-old mother was dying of 3 cancers and about 5 years of progressive debilitation. After about 6 months of going back and forth between the nursing facility in her retirement community and the hospital, spending 2 or 3 days being diagnosed, stabbed in virtually every orifice and virtually every part of her body, coming home exhausted, she finally said to my sister and me, "I am done. I want to die." So we called her primary care physician to get permission to put her into hospice. Her primary care physician, a well-trained geriatrician, said she's depressed. All you have to do is to get her some rest, Give her a couple of uppers. She's a fighter. She'll want to live longer. She wouldn't, the physician said, no, I'm not going to sign her into hospice. Second opinion is exactly right. So we went to her oncologist and said, what? Who said, what? Of course. My mother died with my brother, my sister, and me at her side after 2 weeks in her apartment with a nurse aide, exactly the way she wanted to. That's what I mean by the need for the patient to be a partner. I don't think anyone believes in the notion that the patient should decide what the treatment is without expert guidance and help and partnership. But we have to take into account the fact that in one study that JAMA did, reported in the late 90s, or the mid-90s, I believe it was, on women with breast cancer, diagnosed with breast cancer, that about a third of women want the doctor to tell them what to do after they've had a conversation. About a third of women want to decide that in collaboration with the doctor, and about a third of the people want to say, give me your advice, doctor, and then I'm going to go to all the other sources and I'm going to make up my own mind. People are very different. And what we find out about this is we have to be in collaboration and partnership with patients. So I don't want a straw man to get in the way of what I think is a very important point, and that is patients are partners in this process. The third thing is this notion that that evidence-based medicine is a satanic versus for the Islamic world. You know, this is what people said about Salman Rushdie after he published the Satanic Verses. Evidence-based medicine is not satanic verses, for God's sakes. It is used badly when an insurance company decides based on the current evidence that thou shalt treat this way and we won't pay it for it if you do it another way. However, it is the basis for modern, thoughtful, and ethical medicine, used properly. A straw man that I think we need to just kick away. So, with that as background, let me talk about some things that build on those ideas looking forward. In the report to the Institute of Medicine that was published in 2001, early 2002, called Crossing the Quality Chasm, building on the report that was published in 1999, called To Err is Human, that called out the frequency of preventable medical errors that occur in medicine. The key characteristic of the care system, the delivery system, that needed to change was the concept of integrated care, not pulling together piece parts, lots of hospitals, lots of real estate, not trying to do it all under one governance system, not unifying the back office systems, but integrating what happens to patients. And that's what I want to talk about, because looking forward, there is cause for some optimism. Now, this is the way a doctor thinks about what happens when a patient gets sick. First, that's the doctor, the star. There comes the patient, riding into the office. And I give him everything I possibly can. That's my job, that's my oath, that's my ethical commitment to do everything for my patient and do him no harm. Except, there's the doctor. There's his office procedures, the people who take care of the patient before the patient comes into the room. There's the hospital or the health system and what it does for the patient before the patient ever gets to see the doctor. That's what happens outside the clinical or medical care system before the patient ever decides and gets to the doctor. So there comes the patient who has to traverse that whole damn melange, that whole maze, if you will, to get care. And oh, by the way, once they see the doctor, they got to go back into that same swamp called the social circumstances within which they live day in and day out. Now that's difficult enough because that process from over there on that side, right, where am I here? I don't know if I have one of these things. Yeah, right there. To here is called a care process. And everything that happens from here to here either adds or withdraws, pulls value away from the process of getting what the patient needs and wants. You can imagine, just put your head to it, think about how complex that is. All the things that have to be put in line for that to be effective, for it to be efficient, to be responsive, human, timely, use resources well, safe. Except most patients with chronic diseases have to go through 5, 7, 10, 12 of those things. Because the average number of physicians that a patient with a chronic illness has is about 6 to 8. My mother had 12. Every one of whom, as shown here, has a different one of those care processes. So what you end up with is something that looks like that. That's the typical patient experience. Not only in the US, but virtually everywhere that has a high degree of subspecialization, which is the natural response, the appropriate response, the absolutely right response to better science. My great-uncle was a superbly trained, Johns Hopkins, Vanderbilt-trained internist for many, many years in practice in Portland, Oregon, who used to say that when he got into practice in 1920, he carried everything that there was known about medicine in his black bag. Think about the last 2 days and imagine trying to do that through the brains of a single generalist physician. You can't. It's a pipe dream. So this is our reality, and of course, quite naturally, it confuses the hell out of patients when they leave this kind of system. They say 65, 70% of the time, I don't really understand what I have. These bozos don't seem to know what the right hand and the left hand are doing. I have no idea what I'm supposed to do next. And oh, by the way, I've got to mediate that back in this swamp called my social environment. This is our reality. I want to come back to that in a minute. But that's what's driving, that whole reality is what is driving what we mean by care integration. Because until we coordinate what happens, and until we do that in collaboration with the patient, and come out with coordinated, integrated, compatible treatment and diagnostic and treatment recommendations, we're going to perpetuate this confusion for patients. But there's something beyond it, and that is that confusion is also accompanied by a higher risk of injury and harm because the right hand doesn't know what the left hand is doing. That's especially true in hospitals. It is not documented in the ambulatory space, but we know that the more people who are helping take care of you who are not coordinating, the more handoffs there are, the more opportunities for miscommunication, the more opportunities for drug-drug interactions and all of those sorts of things. So what's driving the need for care integration is the fact that care has gotten so complex that the model of the independently practicing physician has become obsolete. It does what I described in the preceding slide. I would also argue, and this is extremely controversial, but the model by which we have defined ethical physician behavior, which is I have my patient and I will do everything I can possibly for my patient, actually results in unethical care. Because what it also means is that each doctor in this chain of people who are taking care of the patient is doing exactly the same thing, independent of the others. And the result is an accumulation of potential harm, preventable harm, deaths, harm, ineffective care, wasted resources, lack of social responsiveness and timeliness, all of which are, in my view, unethical. That's an important point. I want to make a couple more about this whole issue. We've been talking about this in various forms. This is just my diagram of a normal distribution of a population. And basically what it says is most of us are normal. Some are in transition, and some of us are sick. Sick is aberrance. It's deviance from a statistical point of view. And what we want to do as we think about integrating care and the care stream, the care value, is decide where in this process we're going to start the clock. The more science we have, the better markers we have, the further we can move this way with appropriate ways to identify people and help them to keep from moving in this direction with any particular pathology. Conceptually, that's very important. About 99.5% of the resources in the United States and the rest of the world go to take care of people at this level who are deviants, statistically, from a population point of view. I once consulted for a week or two in Egypt, and we were trying to work with the Ministry of Health about reallocating resources in a country that has foul water, myriad infectious diseases, poor vaccination rates, and spends 99% of its resources on sick care. And again, couldn't move the needle because we all spend our time worrying about that. So what we have in thinking about care integration, as we go about designing value streams or approaches and systems to respond to patients, is we can focus at this level, trying to make the sick care really much more integrated and better, and should, because it takes a huge amount of resource and a lot of damage occurs there that is avoidable. We can go upstream as we get better science, better molecular markers with screening and early detection, with secondary prevention to modify or moderate the risks. And we can go upstream as further than that, as was spoken about this morning with, for example, obesity, into the health and wellness area. That's a choice. It's a design choice for where we intervene in trying to create these integrated systems. The other idea that I want to bring into play has to do with the use of, the practical use of evidence-based medicine. Evidence-based medicine at this juncture is about good enough that we can describe roughly what the boundaries are within which we should be practicing and outside of which the care is crap. We did this with, I think I mentioned this 2 years ago. In pediatrics, we asked 15 pediatricians in one of our programs in Southern California. We asked 15 pediatricians who practice next to each other how they took care of kids with moderate to severe asthma. How many different ways do you think there were? 20. It depended on the day. Some days I do it this way, some days, yeah, you're absolutely right. Now, the evidence suggests and by the way, this is the appropriate use of evidence-based medicine. The physicians met with people who helped gather the information and in some instances interpret it from a scientific point of view, and together they decided that the current standard suggested that there were probably 3 or 4 ways they could take care of it. So what they ended up doing was creating boundaries for acceptable care. Now, until you do that, you can't distinguish between noise and signals. And until you have signals, you can't improve anything. You can't learn. Now, the nice thing about this principle is that these boundaries can be established by best practices. If you do it in collaboration with patients and their families, these boundaries become markers for what is acceptable both from a technical point of view and in terms of the quality of the interaction and the caring, the social environment that you create for patients. The importance of this lies in the next principle of care integration, which is that in fact we are not trying to come up with a point solution. In fact, we will never get to perfection because patient conditions change, the science changes, and every time you get one of these guys, a signal, you want to go back in and figure out why the heck it happened. And it becomes an opportunity to learn. Now, Brent James, my friend and colleague at Intermountain Healthcare down south of here, likes to say there are only a few reasons that you get this happening. One is because the people doing it or the individual physician doing it is a bozo. Doesn't know what the hell he's doing. So it's a signal of malfeasance, ignorance. That has a remediation. 90% of the time, or 95% of the time, it's education, because none of us wants to be a bozo. It could be an error that was simply an honest error. Rarely is it a situation where you have a recalcitrant individual who simply refuses to accept the science. But if you do, that's probably a nice opportunity to say to him or her, I'd really like to compete against you. There are a couple of other reasons. And that is, and the most important of these is that these boundaries are wrong. This becomes evidence that can help in enriching the array or the standards that we set, the boundary conditions that we set. It's a learning opportunity. And that's why what you have in these environments where you set boundary conditions and you set up the capacity for people to learn, analyze what happens, and continuously improve and modify and make better the outcomes, you get this kind of spiral like this learning spiral that is never ending. Now, does this really work in medical care? I mean, this sounds like artificial crap. Well, let's look at Theta Care in LaCroix, Wisconsin. Here's what happened with myocardial infarction. By the way, they've been using this technique. It's called lean production technique. It's used by most other successful industries. Healthcare didn't believe it. For 30 or 40 years. It's Six Sigma, it's continuous quality improvement, but it's really institutionalized in very effective ways. So here's what's happened at Theta Care. Let's just take something simple like myocardial infarction. The standard set by the American College of Cardiology is that you should be able to take care of a patient when he hits your door within, initially it was 120 minutes. You should have from the time he hits the door till he gets a balloon in him and gets angioplasty or gets whatever the key therapy is. Started at about 120 minutes. And Theta Care, when they did the first measurement, was at 75% compliance. They did that 75% of the time. Oops. So they started doing this improvement process stuff. Well, meanwhile, the ACC changed the standard to 90 minutes. And about 4 years later, Theta Care, going through these improvement cycles, because remember that process that a patient has to wend his way through before he gets treatment? A value stream? That has to all be re-engineered, all changed. About 90%, by the way, in most value chain analyses in most care systems, about 90 to 95% of steps taken in the value stream add no value to the patient. Think about that. So by today, Theta Care average door-to-balloon time is 37 minutes. The best that I've heard reported in any general hospital or healthcare system in the world. Jonathan and I were talking yesterday, and he gave me a wonderful quote from William of Ockham, which is, "What is possible." This is the new possible. The difference between the ACC standard and this, you can do the math, but it results in a number of lives saved. And we know how to get here. We know the system to drive towards greater integration that gets you there. But look at some of these other numbers. Cabbages in 2002, a 4% mortality rate. Through the improvement process, 6 years later, 1.4. The next year, 0. Look at the average length of stay from 6.3 to 4.9 days. Look at the cost decrease, 22%. Okay, so that's Theta Care. Well, let's go near home. Let's go to Denver Health, which is one of the best healthcare systems in the world. Patty Gabbo, who's been leading it for the last decade or more, has, along with Theta Care, Virginia Mason, and one or two other places, embraced and introduced this concept of continuous improvement through lean production models with a vengeance. So let's just take a look at some of these things. Colorado's statewide study looked at level 1 trauma centers from 2007 to 2009. Denver Health has the lowest expected versus actual mortality rates in the state. Number 1 in the state, 74 or 0.74 or 26% below the mean of all the hospitals in Colorado, the best in the state. In 2010, they were among all academic medical centers, they ranked number 1 in actual versus expected mortality adjusted for case mix. 3 years ago, they were 28th. Look at sentinel events, which basically are reportable events to JCO, the Joint Commission, for potentially fatal or serious errors. Look at the frequency. Now, these are small numbers, but in the hospital setting, those are very significant changes. And finally, look at the C-section rate. When I was in medical school, the indication that was given by our chairman of obstetrics and gynecology in response to the question, when do you do a C-section rate? I went to the University of Kentucky Medical School in Lexington. His response to me was tip-off time for the Kentucky basketball game. I kid you not. And the funny thing is, none of us laughed. We wrote it down. C-section rates vary wildly across the United States, and the biggest driver of C-section indication is convenience to the physician or the patient, but mostly the physician. There is a sort of a lowest possible C-section rate below which you begin to get into trouble because you're not doing C-sections that are indicated. But the key is this one, the unexpected full-term fetal mortality, which is an indication that you waited too long or that you did it the wrong way. But look at that number for Denver Health. The last 2 years, they've been the lowest in the state, in the consortium reporting, with 0 unexpected full-term fetal mortality times 2 years. My point isn't to say that Denver Health is fabulous or that Theta Care is fabulous or that Virginia Mason is fabulous. By the way, all 3 of them have improved their bottom lines, have improved their margins, have patient satisfaction, even though I know it was told you, we were told yesterday it doesn't matter. Patient satisfaction, by the way, does translate into loyalty, willingness to listen to what a physician has to say, willingness to follow and continue with the recommendations of the healthcare system and the physician. But these places are reporting levels that are really unprecedented in American healthcare. And all they're doing is applying the principles of production design. God, we hate that term because we take care of patients. But we do it through these care processes that are production processes. They're value chains. You can call them anything you want to dress them up. In my good friend Ian Morrison's wonderful phrase, we can pimp our rides. We can call it whatever we want, but it is production planning. Production planning, it turns out, applied to healthcare with all the sensitivity that's required to make sure that doctors can do what they uniquely can do, and that you can customize the response to a patient the way a physician needs to, given his or her capabilities. Taking all that into account, we find these kinds of outcomes. Who in the world is going to argue against them? And they save money. That's very encouraging. And you can see, because of the principle of signal versus noise, the principle of setting boundaries, that the more precisely we know and diagnose conditions, the earlier we can, the broader the value stream we can create for patients. That's pretty cool. Now let's talk about the consumer health ecosystem that Bill just described. I want to be, oh gosh, I'm sorry, get going here. I want to be, come back to something that we talked about 2 years ago. What's driving what Bill describes is not only technology. Bill mentioned this, but it's the tremendous problem of demographic shifts. In the United States, there are 4 or 5 huge demographic shifts. Aging, we've talked about. Diversity is enormous in the country. By 2050, there will be no majority population, and in places on both coasts, it's going to happen before that. The population of the United States continues to grow, unlike most of the countries in Europe and the developed countries in Asia. The US is much more like India in that sense in terms of having a growing population. But the other part of it is that we have seen for the last 20 years plus a widening gap between those with money and those without. So that's one problem, and the big issue that presents for us is we have no policy, no capacity at the current time to meet that demand. The projected gaps by 2020 are about 40 to 60,000 primary care physicians short and 150 to 175,000 physicians short. And there has been a very slight increase in the number of admissions to medical school. But even were we to double it, it would take between 10 and 12 years before those people hit the delivery system. We're not going to double it. It hasn't changed very much since the mid-1980s. So we have a huge problem in that the sick care system that we have had historically, that is physician-centric, cannot meet the future demand. Couple that with the sorts of things that we've been hearing about all yesterday and today, the kind of technologies, the connective technologies that Bill was talking about in the previous discussion. And you have what is the perfect opportunity for disruptive innovation that in fact is occurring through the use of technology driven by venture money, driven by private equity money, and driven by the fact that we are not meeting the needs of patients now and cannot in the future using the traditional system. What that ends up doing, among other things, is creating the opportunity for us to provide lower cost, even less satisfactory solutions to patients and populations than would be the case if you could put a doctor on every block. That's what Christensen talks about in his disruptive innovation work and the innovator's prescription. Clay talks about the fact that these are the perfect conditions for disruptive innovation when you have the technology, you have the science, and you have a demand. And that's what we have. Now, the consumer health ecosystem that I described in my discussion 2 years ago involved what happens at this side of the sick care system. It's in primary care, where we are not training enough primary care physicians, haven't been for about 30 years, by the way. And in the pre-primary care or public health area, what we've talked about in prevention, in health and wellness, there are lots of different words for it. But the point is, we have never been terrific at this, or at least in combining that with the sick care system. Our preponderance of focus has gone into the sick care system. We do a lousy job in our end-of-life care system. And when you have this kind of a situation aggravated by the lack of supply and a growing demand, especially for minority populations, there will be solutions. This is not going to not be met. And the good news is, entrepreneurs like Bill and others have begun to search for ways to meet that need. So what's happening? I said this 2 years ago, and I want to revisit it. We're still experimenting. What you heard today from Numera was an experiment. The uptake is slow, as Bill said, but the capabilities are broadening. The science and technology and capital are not inhibitors. That's really important. They will help us move this faster. But even now, we have virtually everything we need to do many of these innovations. That's a surprise to people. Remember that the average number of connected devices in the population of the United States right now, of connected devices, either the internet or mobile, is, I think it's currently 1.5 devices for every man, woman, and children in the United States. And that's the technology, ubiquitous technology that we're building these sorts of solutions on. What we're searching for, and you heard this in the previous conversation, are the business models, how you scale it, how you get it to market, and how you work with consumers to figure out how to make it in the best possible ways to meet their needs and their expectations. By the way, that's what consumer products companies do every day. And that's where a lot of the impetus for this is coming. Now, who's interested? Well, a lot of strategic buyers, and I would describe some of these as still players, although that's changed, the list has changed somewhat, but you can look for yourself. What's interesting is that private equity players are looking for small experiments to roll up into more powerful, scalable opportunities. We're going to look at one of them. It's called Univita. You'll see it up here in a minute. Employers are looking for these things. Consumers are looking for these things. Outside the U.S., we're looking for these things. And guess what? Most care systems are not. They are continuing to head into the wonderful past of trying to build physician-centric solutions to a demand that they cannot meet. It's called the medical home. It's called training more family doctors. It's called team-based care, which I happen to believe in. All of those are wonderful, but they're not sufficient. Doctors hate it, for the most part, have resisted it, saying, look, if it's not a doctor, it's not good enough. That ain't what patients say. They say, help me. Rand did a very interesting study, reported a year and a half ago in Health Affairs, looking at primary care, looked at all of the evidence about the effectiveness of primary care, and the conclusion was primary care is really important. What's not important is where it's given or who gives it. Payers are not very interested in this. It takes 3 to 4 years to get a payer to do something new and pay for it, whether it's a drug or a new delivery system. Hospitals aren't. And public policy makers, thank God, didn't touch it in the Affordable Care Act. And I say that with great affection for the Affordable Care Act. Thank goodness we have it. God help us if it gets thrown out. That's a different story. Let me give you 2 or 3 examples. I mentioned SomaLogic, one of our favorites, moving forward with their multiplex capability. Larry and his team have made enormous progress and the potential for the wellness chip moving upstream in early diagnosis and early intervention continues to grow. Very, very exciting. MedExpert, I talked about 2 years ago, a navigation system. They now have over 2 million people enrolled in that program. Red Brick Health is a wellness and prevention program directed to employees and their dependents. Proteus Biomed is a very interesting on-body, in-body monitoring system. A gastric acid activated chip on a pill. It's actually embedded at the tip of a pill. It's the size of a grain of sand. There's a small amount of data that is embedded in that that's activated at the time the pill hits the stomach. It sends a radio wave. Actually, it's not a radio wave, but it sends a wave to a monitor on the body that then is transmitted to the mobile phone and back to whoever is the caregiver and says the pill has been taken. These are the physiologic responses. It is a pill from this particular batch or that particular batch, and by the way, it can handle up to 12 pills. Now that's already been in progress and been in use in experimental pilots for about 4 or 5 years. Interestingly, one that my friend, I don't know where Frank, oh, there's Frank. Frank Prendergast and I were on the board of Proventus, started by Ralph Snyderman, the former chancellor at Duke. That one's out of business. It was sold for peanuts to McKesson, which is continuing to develop it under its U.S. Oncology Specialty Services. Patients Like Me continues. Another one that's very interesting to look at is Alliance Health, which is actually a social networking site for people who connect to one another based on their diagnoses. And it essentially builds on the notion that Jonathan talked about, peers, 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 peers. When people work together, they do a better job of caring for their chronic illness than a physician can. Remember, I'm a physician. I see you. You've got diabetes. I'll maybe see you 6 times a year. Maybe, if I'm lucky, for a half an hour each time. Probably not. Maybe 15 minutes. Okay, 6 times 15. You got the picture. 1 hour and a half in a year. The rest of the time, I take care of myself. Univita is a very interesting roll-up to create a platform that enables seniors to remain independent. Funded by a private individual, Ben Lytle, who was one of the co-founders of what is now WellPoint, and GenStar Capital, which is a private equity firm. So where we stand, very quickly, is that I want us not to fall victim to thinking inappropriately about electronic medical records, about evidence-based medicine, and about patients involved as partners with us, because all of those are essential to moving forward with some of these innovations. About integrated care, the core thing that comes out of integrated care, it has nothing to do necessarily with the specific treatment. It has everything to do with the way patients want to be cared for. Ask your patient or yourself this: do you want to be cared for in a system in which the doctors you see all know what's going on with you and are coordinating their decisions about you with you? Or do you want to get care in a system in which you go to Dr. A and get his opinion and treatment, and then go over to B and get his opinion and treatment about my heart, and over to C and get Jonathan's treatment for me or recommendations for me based on what's going on in my squash, and over here to Dr. D, who's treating my dermatologic problem? And they don't know what each is doing. Now, which would you choose? What's interesting is that care integration, the drive for care integration, is not cheaper medicine. It's better medicine. It's safer medicine. It's more effective. And most of all, we have never found a patient who didn't want it, didn't expect it, didn't think that, in fact, that's what they were buying when they came to you. One last anecdote, and I'll stop. When my mother fell, broke her hip, she was 89. We all have our mother stories. That's how we make these sorts of, you have your children's stories. I know, I remember. My mom's story was this: 89, something like that. She's going to a meeting, very, very with it lady. She goes to a meeting at night. She falls backwards, accidentally, because of a steep driveway, falls back, smacks her hip, breaks her femur, has to have it operated on. Long story short, she gets the operation, bad shoulder too, goes to a rehab facility. She's in the rehab facility. First day they bring her out, and they say, "Okay, Mrs. Jubitz," that's her married name, my stepfather, "we'd like you to take some steps." She stands up. The little lesion on her foot that's been unhealing for about 2 years, the basal cell carcinoma that the dermatologist has been treating, starts to bleed. "Oh, you can't walk today." "No, my dermatologist is treating me. By the way, what medications you take?" "Oh, I take Coumadin." Let's call the dermatologist and find out what's going on and whether or not we can change the medication. Call the dermatologist. He's on vacation. Could we get a hold of his medical records? They're locked up. Can't change the medication. So my mother lay actually in the bed for a week and a half until the dermatologist got back from vacation, because by professional courtesy, the doctors wouldn't interfere with each other's treatment. During the course of my mother's hospitalization and rehab, this brings us full circle to the need for integration, she had 12 physicians, 30 nurses, and 75 to 80 other caregivers who were involved in making decisions that affected her well-being, health, and safety. That's average. Thank you very much.